learned audience, I must give my heartiest thanks and gratitude to Society of Medicine, especially to the scientific committee for selecting me as a speaker on this topic, past, present, and future of anti-hypertensive medication. This is a vast topic. I have just had a humble attempt to throw some light or bird's eye view on this topic with a limited period of time. So we know that the journey of science, especially the contribution was mostly from the Greek scientists, starting from Socrates, who laid down his life for the sake of truth. And the life of Galileo, Bertolt Brecht has told, the aim of science is not to open a door to endless wisdom, but to put a limit to endless error. Few stories in the history of medicine that are filled with more errors or misconceptions than the story of hypertension and its treatment. For many years, until the late 1930s, elevated blood pressure was considered an essential adaptive phenomenon. In 1946, a common misconception was that overzealous attempts to lower the pressure may do no good and often do harm sometimes. And prominent US cardiologist, British physician, warned that lowering BP might be harmful and stated that the greatest danger to a man with high blood pressure lies in his discovery, because then some fool is certain to try and reduce it. Only at the time, severe hypertensive patients were treated with some diet regimen like sodium Kempner rice regimen, including 20 gram protein, only 5 gram fat, and less than 200 milligram of sodium. And that resulted in reversal of some cases of malignant hypertension. In the 1950s to 70s, that period included the innovation of some drugs, starting from vasodilators like hydralazine, thiazide diuretics, ganglion and peripheral adrenergic blockers, and centrally acting alpha-2 agonist, beta-2 adrenergic inhibitors, and a beta blocker inhibitors were developed. The diagnosis of hypertension or definition sometimes is made depending on the concept that when systolic and diastolic values rise above a specific threshold that corresponds to the level of BP, where the risk of cardiovascular complications and benefits of treatment outweigh the treatment costs and potential side effects of therapy. And by different randomized controlled trials and meta-analysis, it was shown mostly that 140/90 or above was a threshold in maximum guidelines, but later on, according to some authorities, it was 130/80. So, most commonly, it is diagnosed, as I was telling, the person's systolic blood pressure in the office or clinic is 140 or more, and diastolic 90 or more, following repeated examination on basal conditions. But American College of Cardiology and American Heart Association guidelines, they differed a bit. They told that elevated BP with a systolic pressure between 120 and 129 and diastolic less than 80. And hypertension started from if it is above 130 or above and 80 or above. According to the national guideline, normal BP is less than 130 and 85, systolic and diastolic. High normal, 130 to 139, systolic and diastolic 85 to 89, and grade 1 and grade 2 accordingly, 140, 159, 90 to 99, and equal to or greater than 160, equal to or greater than 100. And another entity is isolated systolic hypertension. This is the scenario. According to Bangladesh Non-Communicable Disease NCD Risk Factor Survey 2022, between 18 to 69 years of age, (23%) of the population is hypertensive, and above 60 it is 49, around 50%. And all of you know that 50% of these patients are unaware that they are hypertensive. 35% were under treatment. Only 14% among them are really controlled. And globally, 1 in 3 adults worldwide suffer from hypertension, according to a recent study, WHO Global Report on 6 September 2023. And number of people living with hypertension doubled between 1990 to 2019 from 650 million to 1.3 billion. And the picture shows that the increase was much more in our aspects, Southeast Asia and the Western Pacific area, rather than the Europe and North America. Joint National Committee on Hypertension, they are putting a lot of information since 1977. They evaluated and had some guideline on treatment of blood pressure. This report was first published in 1977, and every 4 to 5 years their report is being reviewed until JNC 8 on 2014. This is the step care approach of JNC 1. And as at that time, 1977, we were medical students, we also listened from our teachers that the diuretics was the mainstay of treatment, especially on the initial aspects, thiazide diuretics. And we were habituated in using beta blockers like propranolol, methyl-lopa, or reserpine. And gradually, step 3 and step 4 included to add hydralazine and guanethidine and others. This is some chronological development of JNC 1 to JNC 5 report. And in most of these cases, diuretics was the initial therapy to be followed in the later steps by mainly adenosine inhibiting agents, some centrally acting drugs like clonidine and methyl-lopa, and beta blocking drugs, sometimes alpha blocker, and reserpine was there. Sometimes in JNC 3, beta blocker was the initial drug, and calcium channel blocker was added in 1988. But again in 1993, diuretics or beta blocker was the step 1 therapy for hypertension. This is a JNC 8 picture. Here, during treatment, there's a category according to age. Age below 60 and greater than 60, and comorbid conditions like diabetes, CKD, and other high-risk conditions. Almost the drugs were common: diuretics, calcium channel blockers, angiotensin receptor blockers, or AC inhibitors. These are the main drugs used, to be followed some alpha blockers and other drugs. This is some points of difference between JNC 7 and 8. Firstly, the definitions of hypertension and pre-hypertension, which are well defined in JNC 7, has been not been addressed in JNC 8. Secondly, similar treatment goals had been defined for all hypertensive population, and no distinction between uncomplicated and hypertension with comorbid conditions like diabetes or chronic kidney disease has been made. And the choice of initial drug in patients without compelling indication, in contrast to JNC 7, where thiazides are recommended to be the initial choice of patients without compelling indications. No such recommendation has been made in JNC 8. So, we are following especially our national guideline, which are formulated by our respected members, senior teachers of Society of Medicine, and also senior teachers from the country under the guidance of our NCD department of DGHS. So this is on the primary healthcare settings for primary management of the hypertensive patients, especially to be started at the primary healthcare, that's Upojela Health Complex. And the safest drug was to start with amlodipine 5 milligram once daily. And there are certain things to be followed, that initially all the population above 18 years to be examined about blood pressure. And if there is high blood pressure, then the patient should be advised to follow the lifestyle measurements for control. And within 1 month, if it is not controlled, then to start drug. And after starting drug, to be followed 4 to 6 weeks, whether at that dose or at that drug it is controlled. And gradually, if it is controlled by amlodipine, then to add some AC inhibitor or receptor blockers and thiazide diuretics sequentially. But pregnant women and women, those are going to be pregnant, they are strictly prohibited for ARB or AC inhibitors. This is one algorithm for approach for starting treatment with monotherapy or free combination therapy. Initially it was followed. Now, of course, still it is being followed, monotherapy. And monotherapy to be started with calcium channel blocker at the half usual dose. And if it is controlled, then double the dose. If still not controlled, then to add another drug, especially angiotensin receptor blocker or AC inhibitors. And the patient should be followed every 4 to 6 weeks. And if the blood pressure is controlled, then to be followed every 3 to 6 months. Even with strict investigations, strict care, 50% of the patients getting treatment, BP is not controlled. So, WHO has specially recommended for combination therapy. So, sometimes it is single pill combination, it has been suggested by someone, and to be started with combination amlodipine and ARB, half the dose. Then gradually it is increased and followed up to full dose. Then still, if it is not controlled, to add diuretics. So for better compliance and better control, these policies are being followed. And what are the future or new drug targets for hypertension? So the future is when there is increased molecular development and increased understanding on the pathogenesis of hypertension, it is being cleared. The renin-angiotensin system is a key system which is involved in the genesis or maintenance of hypertension in a population. And we see that angiotensinogen is synthesized in the liver and it is converted to angiotensin 1 at first and angiotensin 2 with the help of angiotensin converting enzyme, all of you know, and it acts on AT1 receptor and AT2 receptor. This called vasoconstriction as well as secretion of aldosterone and sympathetic stimulation. But there are other areas of enzymes, especially ACE2 enzyme that converts angiotensin 2 to another arrays of angiotensin 1 to 10. And among this 1 to 7 segment also stimulates some MAS receptor. And that receptor causes vasodilatation along with stimulation of the AT2 receptor. So, some molecular interventions could be done at these MAS receptors and also AT2 receptors. Also, angiotensinogen is a peptide protein, and at the stage of protein synthesis, interfering with small interfering molecules between messenger RNA that causes decreased angiotensinogen synthesis. So many molecules are at target. Renin, another substance, is at the target for renin inhibition that is secreted from the juxtaglomerular cells of the kidney. Again, aldosterone synthetase inhibitor. Here also some drugs are to be explored, and aldosterone acting on the mineralocorticoid receptor. So these receptor blockers we are using, and some drugs are also in the pipeline. There are some long charts at the molecular targets where there are some drug acting to elevate high blood pressure. Among these, very few are approved, and many of these are in the pipeline on the phase 1 to 3 trial. Among these, aminopeptides A and B. These are some metalloproteases in the brain, and they really metallopeptides causing conversion of angiotensin 2 to 3 in the brain, and angiotensin 3 is a potent vasoconstriction. So if those enzymes can be inhibited, then indirect vasodilation can occur. We know that vasoactive intestinal peptide, it is related to the motility of the gut, but it's have some action on vasodilatation. So VIP receptor agonist, these drugs are on phase 1 trial. Sodium hydrogen exchanger, these enzymes act on the L cells on the small intestine and also kidney tubules. So if this can be inhibited, extra sodium, body can be free from some extra sodium. Then comes endothelin A and endothelin B. These substances are potent vasoconstrictor elaborated from the vascular endothelium. And bosentan, macitentan, darusentan, and aprocitentan, these drugs are already approved, and bosentan is being used. Nitric oxide is a potent vasodilator. Many molecules are in the preclinical stage so that nitric oxide concentration in circulation can be increased for vasodilatation. Sphingosine 1-phosphatol also in that group. We use some drugs for other purposes other than hypertension, especially in diabetes. We use sodium glucose cotransporter 2 inhibitor. We use some GLP-1 agonist like semaglutide, liraglutide. So those drugs not only causes decreased glucose, but they also causes vasodilatation. And we know that canagliflozin and dapagliflozin, these drugs also make body free from extra sodium. So they have some anti-hypertensive effect as well. So this is a rough chart showing the classical drugs we are using for controlling hypertension. Starting from the diuretics, we use potassium sparing like spironolactone, eplerenone, and potassium losing as well. Potassium losing are special diuretics like furosemide, toracemide, and some thiazide-like diuretics, indapamide and chlorthalidone. Central nervous system acting drugs, clonidine, we know, alpha-2 agonist, reserpine, vasodilators, minoxidil, hydralazine, calcium channel blockers, dihydropyridine, non-dihydropyridine groups, renin, angiotensin aldosterone system blockers, ACEs and ARBs, also renin inhibitor. Adrenergic blockers, beta blockers, alpha blockers, and alpha beta blockers. These all we are using day to day. Another drug, valsartan and sacubitril, we are using in heart failure along with hypertension. So sacubitril is a novel molecule that is neprilysin inhibitor, and neprilysin inhibitor can cause increased atrial natriuretic peptide, so that causes diuresis and make body free from sodium, help along with hypertension with heart failure. So in the previous chart, already I have told about the dual endothelin blocker. These are the drugs in pipeline or recently approved. So inhibitors of aminopeptidase, 5-ribestat, and MR receptor, mineralocorticoid receptor blockers, eplerenone, spironolactone, and finerenone. Aldosterone synthase inhibitors, baxdrostat, and these are some pictures of the mechanism of action of these drugs, as I had already mentioned. Gastrointestinal microbiota also have some influence because we take variable drugs, different types of food, and there is elaboration of many short-chain fatty acids, some aromatic toxins, food adulterants. Everything may cause dysbiosis, and that dysbiosis may affect salt sensitivity of the kidney. So retention or excretion of sodium, many instances depend on this gastrointestinal microbiota. So manipulation in this aspect can help in the control of blood pressure. This is a chart of some parenterally used antihypertensive drugs, all of you know. This is the sartan family, starting from the journey from 1986. And the latest sartan is fimasartan. We have not got it yet. That was introduced in 2012. So this is the picture, devastating picture. Globally, among 750 crore population worldwide, 110 are living with uncontrolled hypertension. And alarming is that 20% of them are resistant. And in Bangladesh, among 17 crore people, 4 crore people are living with hypertension, and around 53% of them are uncontrolled or resistant. This is another real picture, as we previously showed that above 60 years of age, about 50% population are suffering from hypertension, and aged population mostly suffer from other comorbid conditions. And in this picture, there's diabetes is the mostly incriminated, along with the obesity and other components of the metabolic syndrome. So many patients, as we day-to-day treat, come with us not only with hypertension, but along with diabetes, obesity, dyslipidemia, NFLD, other neurological problems, and they're complicated. If it is complicated, then heart failure or stroke or retinal involvement. To highlight about some newer drugs, as our today's sponsor, SKF is introducing one drug, moxonidine, centrally acting drug. We are used to using two drugs, methyl-dopa. Still, it is very much important for pregnant ladies. And clonidine, in some cases of refractory or resistant hypertension, they actually alpha-2 adrenoceptor, alpha-methyl-dopa and clonidine. They have action on salivary glands and nucleus ceruleus to cause dry mouth and sedation. And clonidine also have some effect on nucleus subtractus solitarius to have some inhibitory effect on sympathetic nervous system. And moxonidine and rilmenidine, that has novel action. They have no effect on nucleus ceruleus or salivary glands. They, through the rostral ventrolateral medulla oblongata, have some inhibitory effects on sympathetic nervous system. So we welcome this new drug. This is some management picture of treating resistant hypertension in the primary care setting. And in this, alpha blockers and centrally acting sympatholytics, especially clonidine, methyl-dopa, and direct vasodilators have some place. Some vaccines are also in the pipeline, especially angiotensin 1 vaccine, consisting of an angiotensin 1 analog conjugated with tetanus toxoid carrier protein and adjuvanted with aluminum hydroxide, reduced blood pressure in rats. So that will act on the angiotensin 1 receptor. We welcome and we want the success of this vaccine, like communicable disease. So before selecting an antihypertensive drug, the main principles all of the physicians follow is that efficacy of the drug, the rarer or less side effects, it is cost effectiveness, and especially the compliance part. Before selection of the drugs, also we consider the risk factors and target organ involvement. So drug group may change in particular contexts. এখন আমি একটা বাস্তব সিচুয়েশন, আমি এখানে যারা উপস্থিত আছেন সিনিয়র টিচার্স and our physicians, all of them are treating hypertension, and gratefulness to all of them because they are making our patient's life worthwhile and disease free. Especially I must remember with respect Professor H.G.M. Chaudhary sir, who worked for hypertension, and many physicians still in different medical colleges. They maintain hypertension clinic and specially treat hypertensive patients and do research on the topics. I must show my respect to Professor Zakir sitting in front, who is working for hypertension and has been recognized nationally. Hypertension চিকিৎসা আমরা সবাই করি। আমি এখন বাংলায় কিছু বলি কারণ আমার শেষ কথাটা বাংলায়। হাইপারটেনশন ডায়াগনোসিস যেমন আমরা জানি ডায়াগনোসিস কম হচ্ছে বা হচ্ছে অনেক পরে হচ্ছে, যখন ডাক্তারের কাছে আসে বিশেষ করে টারশিয়ারি কেয়ার লেভেলে, ওর তো হাইপারটেনশন নিয়ে আসে না, কেউ মাথা ব্যথা নিয়ে আসে, কেউ বুক ব্যথা, কেউ অ্যাঞ্জাইনার পেইন, কেউ হয়তো ট্রানজিয়েন্ট ইসকেমিক অ্যাটাক অথবা স্ট্রোক হয়ে গেছে। তারা বিভিন্ন স্পেশালিটির কাছে যায়। অনেকে যাচ্ছেন কার্ডিওলজিস্ট, তাদের হার্টের সমস্যা নিয়ে উইথ হাইপারটেনশন, নিউরোলজিস্ট হয়তো ট্রানজিয়েন্ট ইসকেমিক অ্যাটাক অথবা স্ট্রোক হয়ে গেছে, ইম্পেন্ডিং স্ট্রোক, হাইপারটেনসিভ এনকেফেলোপ্যাথি। তারা ডায়াবেটোলজিকে যাচ্ছে, যে ডায়াবেটিস আছে সাথে কোমরবিড কন্ডিশন। তারা পালমোনোলজিস্টকে যাচ্ছে, অ্যাজমা সিওপিডি আছে। প্রত্যেকেই কিন্তু উইথ ডিউ রেসপেক্ট টু দোজ ফিজিশিয়ানস, প্র্যাকটিক্যালি হোয়াট ইজ সিন যে অনেক স্পেশালিটি কিন্তু শুধু তাদের পার্টটুকু হাইলাইট করেন। একজন রেসপিরেটরি ফিজিশিয়ান উনি অ্যাজমার ওষুধ দিয়ে লিখে দিলেন, অন্যান্য ওষুধ চলবে। একজন নিউরোলজিস্ট উনি হয়তো নিউরোবি অথবা কোনো সিডেটিভ ড্রাগ দিয়ে হয়তো প্রেশার ওষুধ লিখলেন, তার মতো করে লিখে দিলেন। একজন ডায়াবেটিস রোগী, ডায়াবেটিসের পোর্শন থাকলো, প্রেশারের অংশটা আনটাচ থাকলো অথবা ওষুধ লিখলেন। একই পেশেন্ট তিনজন ডাক্তারের কাছে যখন আসে তখন সে কিন্তু খাবি খায়। সেই ক্ষেত্রে একজন ইন্টার্নিস্ট স্পেশালিস্ট অন ইন্টারনাল মেডিসিন স্পেশালিস্ট ক্যান হেল্প ইন দিস অ্যাসপেক্টস। আওলাদ মহিপুরের একজন ভ্যান চালক, বয়স 45 বছর, দিন আনে দিন খায়, অভাব তার নিত্যদিনের সাথী। নিজের বলতে আছে শুধু ভিটে মাটি, এক টুকরো ধানি জমি আর ছোট্ট একটা পুকুর। হাইপারটেনশনের উপসর্গ নিয়ে গ্রাম্য হাতুড়ে ডাক্তার শরণাপন্ন হন। 100 টাকা ভিজিট দিয়ে ইস্টিমেটিল খাওয়া শুরু করেন। ভেবেছিলেন সেরে উঠবেন সহসাই, কিন্তু না। আরেকজনের কাছে গেলেন, সেখানেও উনি ফ্লুপেন্টিক্সল মেনিট্রাসিন দিয়েছেন, এবার একটা ঘুমের ওষুধ দিয়েছেন। আওলাদ সাহেব কিছু সাইড ইফেক্ট হচ্ছে, হাতে কাঁপুনি ধরেছে। অবস্থার অবনতি হলে উপায়ন্তর না দেখে 5 বেবি হেলথ কমপ্লেক্সে যান। দায়িত্বরত চিকিৎসক রোগের বিস্তর জটিলতা বিবেচনা করে ঢাকায় রেফার করেন। কিছু একটা ওষুধ অবশ্য লিখে দিয়েছিলেন। মাথায় আকাশ ভেঙে পড়ে আওলাদের। ঢাকা কত টাকার বিষয়। কিছু টাকা ধার এবং ধানি জমি বন্ধক দিয়ে ঢাকা আসার বন্দোবস্ত করেন আওলাদ। ঢাকায় আসেন, হাসপাতালে যান। ডাক্তারের কক্ষের সামনে গিয়ে তার মাথা চড়ক গাছ, এত মানুষ। সিরিয়াল নিয়ে বসলেন, একটু পর ঘড়ি দেখছিলেন, এই বুঝি সিরিয়াল আসলো। ভিড় ঠেলে ডাক্তার কক্ষে প্রবেশ করলেন, সেখানেও ভিড়। প্রবেশ করা মাত্রই একজন নার্স এসে কোনোরকম তার প্রেশার মাপলো। ডাক্তার নিজে মাপেননি। চেয়ারে বসে থাকা বড় চিকিৎসক শুধু একটি প্রশ্ন করেই একখানা স্লিপে কিছু ওষুধ লিখে দিলেন, কিছু ইনভেস্টিগেশন লিখে দিলেন। দু একটা কথা অবশ্য জিজ্ঞেস করেছিলেন। কক্ষের বাইরে আসলেন আওলাদ, ভাবলেন হয়তো তার রোগ ভালো হওয়ার সময়ের ব্যাপার। ফার্মেসিতে গেলেন, কর্তব্যরত দোকানদার বললেন 10টি টেস্ট এবং 6টি ওষুধ দিয়েছেন ডাক্তার। 6টি ওষুধের 1 মাসের কোর্সের দাম 8,000 টাকা। এভাবে খেতে হবে আজীবন। আজীবন বছরে 96,000 টাকা। কোথা থেকে আসবে এই টাকা? নিকটস্থ ডায়াগনস্টিক সেন্টারে গিয়ে জানা গেল টেস্ট করাতে প্রয়োজন 10,000 টাকা। মাথায় যেন আকাশ ভেঙে পড়ল তার। কোথায় পাবে এত টাকা? অকস্মাৎ ফ্লোরে বসে পড়লেন। অশ্রুসিক্ত চোখ আর কষ্টের দীর্ঘশ্বাসে ভারী হয়ে উঠল ডায়াগনস্টিক সেন্টার। এরকম শত শত আওলাদের আর্তনাদ ঢাকার আনাচে কানাচে। কে দেবে আশা, কে দেবে ভরসা? এটি শুধু আমাদের দেশে না, তৃতীয় বিশ্বের বেশিরভাগ জনগোষ্ঠীর কিন্তু পিকচারটা এরকমই। আসুন আমরা আমাদের জায়গা থেকে এরকম আওলাদদের সঠিক চিকিৎসায় গুরুত্বপূর্ণ ভূমিকা রাখি। So Mr. Bertolt Brecht, the aim of science should be to open a door to endless wisdom for a world worthwhile and divine for hypertensive. Thank you.